All right, so this is going to be your lecture recorded on cardiac pharmacology that you're going to need to know. And I've shared all the information that I expect you to know in the handouts, as well as things that we'll talk about in this recording. So please make sure that you're very familiar with it, because everything that's on that paper is subject to being presented on your exam. So there are some important terms that we need to discuss first before we get into the actual pharmacology. First pass metabolism are the meds that are absorbed through the GI tract, pass through the liver first, reducing the amount available for the body. So this only applies to medicines that are given orally to our patients. One way to look at this would be when you get your paycheck. Let's say that you make $1,000. That's not the amount of money that's going to be available for you to live off of. First of all, you may have to pay $350 for federal tax and $150 for state tax. When you take that out, that totals up to $500, and that leaves you with $500 left for you to function on. The first pass metabolism is basically kind of like the taxes that are taken out of your money. If we put this into more of a pharmacological type of process, let's say that you administer 1,000 milligrams of a drug. 350 of it is not absorbed by the intestine and thus is passed out of the body when the patient has a bowel movement. 150 milligrams of that is metabolized or neutralized by the liver through the process of first pass metabolism. Therefore, the take home, or what is going to be available of that drug to actually work, is going to be 500 milligrams. Now, I'm not going to ask you to remember what the different first pass metabolism rates are or the numbers that go along with specific drugs. But this is an important concept for you to remember, because you have to understand that in certain situations, you may be given a higher dose, also known as a loading dose, of medication than you normally would on subsequent doses, because we have to get the levels up as a result of these two types of things that are going on there. Half-life of a medication. Half-life of medication is defined as the amount of time that it takes for 50% of that medication to be metabolized. Now, thing to remember when we're talking about half-lives of medication is that research says that once 5 half-lives have occurred, then we can work safely off the assumption that that medicine has now been eliminated from the body. And a lot of that depends upon the different lengths. So we will talk about some medicines such as adenosine, which has a half-life of about 10 seconds, as compared to another medicine that starts with A, amiodarone, which has a much, much longer half-life that may have the medicine remaining in the patient's body for many months. Now, this is going to be key for you as the role and the practice of the paramedic expands beyond just pre-hospital. And now we're moving into both hospital and physicians' offices, as well as potentially into dental offices, of making sure that we know how long a medication with its effects and side effects might be affecting our patient as far as when we're administering those medications. Loading dose is defined as a rapidly delivered and usually a large dose to elevate the blood levels to an effective level. Now, this comes back to what I said a while ago about first pass metabolism. Generally, the loading dose is going to be higher on the first dose that we're given to accommodate or to make plans for the fact that we know that some is going to be eliminated and some is going to be metabolized. And we help to offset that to get the medication up to a therapeutic action window by giving a patient a loading dose. Agonist and antagonist. An agonist is a medication that causes something to happen. For example, if we give epinephrine, we know that it's going to cause the heart rate to go up. So that is an agonist in that regard. An antagonist is the exact opposite. It blocks something. It keeps something from happening. The most common antagonist that you're going to administer is probably going to be Narcan. It blocks those opioid receptors on the brain and allows our patient to wake up and begin to breathing again. Therefore, it's classified as an opioid antagonist. Alpha-1 receptors. Alpha-1 receptors are primarily located on the peripheral blood vessels. Stimulation of these receptors can cause vasoconstriction. Dopamine is an alpha-1 medication. We give dopamine. It primarily has little effect on the heart rate, but it causes massive peripheral blood vessel vasoconstriction, thus raising the blood pressure. We'll talk more about the positives and negatives of dopamine. Dopamine for right now is beginning to kind of fall out of favor in preference for more of like epi and norepi push dose pressors. Beta-1 receptors. Beta-1 receptors are cardiovascular in nature. When beta-1 receptors are stimulated, they increase the heart rate and the contractility. So what is the end result of the stimulation? Well, that raises up the blood pressure. When we give a patient a beta blocker, if a patient takes a beta blocker, these beta-1 receptors are dampened down. It slows down the heart rate and it decreases the contractility with the end goal of dropping the blood pressure. So it's not unusual for your patients who have a history of hypertension of being on a beta blocker. Beta-2 receptors are located in the bronchial smooth muscle. When we stimulate this, it causes bronchodilation. Epinephrine is a bronchodilator. It's a beta-2 activator, agonist. Albuterol will cause bronchodilation. It is a beta-2 agonist. It causes that to happen. So when we're looking at things that really do cause and have an impact on drug metabolism, make sure you're familiar with these. Number one, age. The very young and the very old have more side effects from medication administration than do those that are in the middle. Why? Because the very young have not had their metabolism systems fully developed yet. The very old, because they're ineffective, or they're not as effective as they were when these people were younger because of the age, and because of age and disease, in particular within the liver, also known as the hepatic, or the kidney, known as the renal. They may have disease processes that keep these from functioning. The route. If we want to give a medication and have it onset the quickest, we're going to give it IV. A second way of giving medication that will begin really quickly would be if we give a medication via inhaler. Remember, that medicine is going to go straight into the alveoli, and the alveoli are covered with hundreds of capillaries, and that medicine as a gas particularly is going to diffuse across that and get into the bloodstream really quickly. One of the slowest ways that we can do is that we can inject it into the fatty tissue. There's not a lot of blood circulation within fat. And so we may indeed do that when we want a slower onset of a particular medicine. The dosage. We've already kind of talked about this when we talked about giving a loading dose for our patient. Generally, we know that a higher dose is going to, in most situations, have a higher onset with all other things being equal. The genetic predisposition. This is going to have a role to play as far as whether a medicine has a tendency to work on a patient or not. So, for example, with my wife, when she has had surgery in the past, she has had to make sure that they understand that they do not give her a full dose of pain medicine because they need to start out with a half dose. She gave me my first kidney transplant back probably 25 years ago down at Emory in Atlanta. They didn't listen to her, and they just about killed her because they gave her a full dose of pain medicine and it put her into congestive heart failure. And so when your patient tells you, hey, I'm very sensitive to this drug, make sure you listen to them. Diet or starvation. So if we were giving a patient a medicine PO, or by mouth, PO meaning by mouth, and there's a lot of food in their stomach, that's going to slow down the absorption. So you might want to kind of keep that in mind when you're administering aspirin to your patient, because we want that aspirin to begin as quickly as we can for cardiac patients. That's why we have them chew it up first. But then again, as they swallow it, it's going to be taking longer to get into the bloodstream if they've got a full belly, as opposed to whether they've got nothing in their stomach at all. Flip side of that is that if you have a patient that has really, really poor nutrition, such as we would see with chronic alcoholics, who potentially could be literally in a starvation status, medication will also take longer to begin going in. And then lastly, the current disease state. If our patient particularly has poor gastric motility, if we're giving an oral medication, or if they have poor circulation because of a disease process, then that medicine is going to take longer to get into the system, thus taking longer to begin to work. Go back and make sure you understand these concepts as we are moving through. All right, so the first one we're going to take a look at is a really, really important cardiac drug, and that's aspirin. The abbreviation for aspirin is ASA. It is known as a platelet aggregation inhibitor, commonly called blood thinner, but it does not thin the blood. What it does is it inhibits the formation of clots rather than thinning the blood. The administration of aspirin is a major, major part in the reduction of morbidity and mortality in patients that have a heart attack. Basically, how does it work? Well, it blocks the formation of the substance known as thromboxane A2. Thromboxane A2 causes platelets to get sticky as well as arteries to begin to constrict. As a result, there's an overall reduction in mortality associated with an MI because it keeps the clot from getting worse. Chronic use or a long-term use of aspirin also appears to reduce the rate of non-fatal reinfarction or having another MI, as well as the reduction of patients who are having strokes. Basically, what we're looking at here is that this depends upon how much food is in their belly, but onset is in about 5 to 30 minutes. Again, this has to be with non-enteric coated aspirin. We'll talk about that in just a minute. It peaks out anywhere. It has a wide range of peaking out from 15 to 120 minutes. And again, this depends upon the absorption that the patient has within the GI tract. Generally, we're looking at about 1 to 4 hours duration, which gives us plenty of time to be able to get our patient into the cath lab. The half-life is generally about 15 to 20 minutes. I would expect you to know the aspirin half-life simply because it's such an important cardiac medicine. Now, aspirin is used for new chest pain that is suggestive of acute coronary syndrome. Several studies have shown that early aspirin administration, generally within 3 hours of the symptoms of chest pain coming on, is associated with a significantly decreased risk of death in your patient. Now, keep in mind that there are some other studies that aspirin is underused in the pre-hospital care in the treatment of chest pain and acute coronary syndrome. This will be the most important drug that you are going to give to your patients. If we run you through a simulation or I give you a scenario and aspirin is indicated and you fail to administer aspirin, it doesn't matter to me how good you are on everything else. You will automatically fail the scenario. Aspirin and other non-steroidal anti-inflammatory drugs known as NSAIDs have been found to trigger asthma attacks in people who have asthma. The asthma attacks are often induced by aspirin, and NSAIDs are quite severe and can be quite life-threatening. Again, what you have to do is you got to weigh your balance out. If the patient tells you, hey, I don't take aspirin because it causes me to have an asthma attack, but you've got this patient that's having substernal chest pain and it's classic cardiac type of pain. You've got an elevated ST segment in 3 contiguous leads or more. I would strongly encourage you to have the patient take the aspirin. Obviously, they are going to have the final say in what they take or what they don't. Now, aspirin can cause GI upset and bleeding. Okay, aspirin should be used with caution in patients who report allergies to NSAIDs, and this is going to be true for all of your patients. Doses higher than recommended can actually interfere with the positive benefits of being an anticoagulant. So that's why we're only going to follow the dose that's outlined within your protocol. Some of the side effects that we would see with aspirin are all primarily going to be GI with just a couple. Heartburn, GI bleeding. Occasionally you'll have patients that will have some nausea and vomiting. If it precipitates an asthma attack, your patient may have some wheezing along with that. So listen for breath sounds before and after if in your history, and you will have gotten a history, right? Because you're going to be great paramedics. You're going to have gotten a history to find out if there is any negative indications for withholding this aspirin. And then obviously prolonged bleeding. This is normal for a patient that is on long-term use of aspirin. When administered together, aspirin and other anti-inflammatory agents such as ibuprofen can cause an increased number of side effects, as well as a synergistic effect of the increased blood levels of both medications. This could lead to the potential of having more of the side effects that we just discussed. When we give aspirin to a patient with antacids, it reduces the blood levels of the medication by blocking absorption. Again, this is one of the reasons why we find out, has our patient taken any type of medication prior to our arrival? Many times your patients are going to mistaken having cardiac pain for some type of a GI issue. It can be substernal burning. And they'll take Mylanta, Maalox, Tums, or whatever. Just to understand that your aspirin may not be as effective as what it would be if they had not taken those antacids. Your dosage is going to be 160 to 325 milligrams of non-enteric coated aspirin chewed up and swallowed. So what in the world is enteric coated aspirin? Okay, I'm glad you asked. Enteric coated aspirin is given to patients who need to be on long-term aspirin therapy but who have the GI side effects with aspirin. It's coated with a special coating that does not allow absorption in the stomach but holds the aspirin intact until it passes through and into the intestinal tract, where there are many, many fewer nerve endings, so the pain and discomfort is going to be much less. If our patient chews and swallows enteric coated aspirin, then the onset of aspirin may be delayed by as much as 90%. And that's why we always give our patient non-enteric coated aspirin. Some of your protocols may call for you to utilize baby aspirin. Now, it's kind of an oxymoron in the fact that we don't give anybody under the age of 16 aspirin because it can cause a condition known as RAYS, REYES, RAYS syndrome, that can be life-threatening for your patient. But the taste when the patient chews up the aspirin is just a little bit better.